The PRL is for sure a prognostic biomarker. We know very well that patients who have PRL at the time of diagnosis or at the time of treatment start have a higher risk of disability progression in the future. Whenever an optic neuritis happens, either whether it's clinically symptomatic or asymptomatic, both can happen, then after 2 to 3 months, the earliest, and afterwards basically forever, there is an asymmetry. A combination of OCT together with VEP in the context of acute optic neuritis is a very good combination to, on the one hand, give you myelin via the VEP or remyelination, and on the other hand, measuring neuro-axonal damage over time with the OCT. Hi, I'm Gabriel Bsteh. I'm a neurologist from Vienna. I'm head of the MS group there, and I'm also fortunate to be a member of the executive committee of ECTRIMS, and happy to join you on the podcast today.
And I'm Brett Drummond. You're listening to the ECTRIMS Podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Welcome to today's episode, where we're shining a spotlight on the role of imaging in multiple sclerosis. MRI has already transformed the way we diagnose MS, and with the latest updates to the diagnostic criteria, imaging is now more deeply embedded than ever before. But its impact doesn't stop there. Researchers are working to identify new imaging biomarkers that can track disease progression, predict outcomes, and even guide treatment decisions. And in clinical trials, imaging is becoming a powerful tool to measure whether new therapies are truly making a difference. At ECTRIMS 2025 in Barcelona, I sat down with Gabriel, who works extensively in the imaging field with a particular focus on developing biomarkers that may allow for a shift towards a more personalised medicine approach. Gabriel, thanks for joining me.
Nice to meet you, nice to see you, or hear you.
So I guess it's a very logical place to start with the diagnostic criteria, new diagnostic criteria having been released in 2025, that we start there. We can't really have a conversation about imaging without talking about how this has now been included or included in a different way in this. Can you talk us through the imaging inclusions that have been put into those revisions and why you think they're an important part?
Yeah, as you said, you cannot start a conversation about biomarkers or basically any conversation about MS now without talking about the diagnostic criteria, which are maybe not a revolution, but a very stark evolution of what has previously been done. And of course, to the positive, at least we hope that the community will agree. And imaging biomarkers are a huge part of that. We have evolution of criteria over time, starting with a purely clinical diagnosis to a clinical diagnosis aided by paraclinical markers, which were basically imaging only. Then CSF came additionally to it. And now we are at the point where the diagnosis cannot be made without at least any paraclinical evidence, and that is mostly MRI. But in MRI, we also had an evolution over time. We started with pictures where you had a hard time seeing the brain at all. And we have come to a point where we have not only lesion or no lesion, we have what type of lesion is it, how is this lesion evolving over time. And it's not only is there a lesion or not, and which type it is, but it's also now entered into the criteria. And that is basically the first real change. It's not only counting the lesions and having a fifth region, the optic nerve, we'll come to that later, but also having specific lesions or nearly specific lesions for MS. There are 2 types of them. One is the central vein sign lesion or CVS lesion, which is a thing which we know for a very long time from pathology. We know that lesions form around veins, around very small veins. And now, or over the last decade, we have developed sequences, the so-called susceptibility-weighted images, which enable to picture these veins and differentiate whether a lesion is formed around such a vein or whether it's not. And that's basically it. And what you do for the diagnostic criteria is you look at the lesion, each one of them, or at least you start by looking at these lesions, and you start counting. And when you're up to 6, you're basically finished, and you say, okay, I have 6 of them, and this is the select 6 criterion, which means that you have fulfilled this criterion. Or if you have less than 10 lesions, you take all of these 10 and you say, do I have 5 or more of them, which is the majority. And if these 2 criteria are fulfilled, or one of these is fulfilled, then you can say CVS sign positive. Okay. And in the big framework of the McDonald criteria, which are, of course, a little easier to have it graphically in front of you, But it's important to point out it's not necessary to have that, but it can be an additional help in case you need it. That's an important point to take away. And basically it depends on how many dissemination in space regions you have. And it's especially important if you have 2 or 3, then if you have the central vein sign, you're basically finished. If you have excluded differential diagnosis, so you have 2 or 3 DIS regions and you have a CVS sign positive, that's it. And if you have only 1 region, then you can have the CVS sign and add it to either the dissemination in time, the traditional one, so either new relapse, then it's of course also there, or if you have contrast enhancing lesions on one hand and others which don't, or if you have a positive CSF, so each one of those in combination with the CVS also gives you the diagnosis. And the third application is in the also little controversial part, if you want, in the so-called asymptomatic MS, which was formerly known as RIS, or radiologic isolated syndrome, where you have to have at least the DIS 2 regions or more, and then you need 1 out of 3, and 1 out of the 3 is again the CVS sign. So then if you have never had MS-specific symptoms, but you fulfill this criteria, you still can say this patient has MS. Okay. That's the one part. And then we have another specific MRI sign, which is the so-called paramagnetic rim lesion, or it also goes by iron rim lesions, PRL or IRL. In the McDonald criteria, it's named PRL, which is also something which know out of pathology again. We know that there are some lesions which are not only demyelinating, but which have an iron rim on their outer border. It doesn't have to go all around it, but it has to be at least 2/3 of the circumference. And we know that from pathology for a long time, but again, aided by the susceptibility-weighted imaging, you can also image that. And it's something which is highly, highly specific for MS. It's basically only 2 diseases where we know that this is there. This is MS and also Sussach's syndrome. Sussach's syndrome is very, very rare and clinically easily distinguishable, or should be easily distinguishable. And so when you have the suspicion of MS and you see PRL, you can be highly sure. The problem is a little that it's not very sensitive. So there are a lot of patients who have MS but don't have PRLs. It's like sensitive in up 25% approximately, depending on the cohort. But if you see it, you can be very sure. And that's also the applicability in the criteria. It's again the same framework. You count the DIS regions, and if you have 2 or 3, then unfortunately the PRL is not in there, which is a little bit of a pity. But it is there in the 1 region. So if you have 1 region and you have DIT and CSF on the one side and also PRL, then again you're finished. And that's what it gives you for the diagnosis. So these are the 2 MRI signs. And then we have, we used to have 4 DRS regions, and now we have 5, which is the optic nerve. And the optic nerve can, of course, be imaged by MRI, but it needs orbital MRI, which is a little bit tricky and not always available. So there is additional ways of doing that. That is where my personal thing comes a little into play, because the optic nerve is basically my basic area of research, where I come from. And you can image the optic nerve not only by MRI, but also by OCT. It's called optical coherence tomography, which is a very easy investigation known to ophthalmologists for quite some time. And it enables picturing the retina, or the most anterior part of the retina, where the optic nerve begins to form. And whenever an optic neuritis happens, either whether it's clinically symptomatic or asymptomatic, both can happen, then after 2 to 3 months, the earliest, and afterwards basically forever, there is an asymmetry. So when an eye suffered an optic neuritis, there will be a difference between right and left eye. And over time, we have developed cutoffs, so how different it has to be, how asymmetric it has to be. And there are basically 2 layers, which hopefully are now known to most of the field, but will grow over time. One is the so-called PRNFL, or peripapillary retinal nerve fiber layer. This is basically the axons of the optic nerve. And the other is the so-called GCIPL, ganglion cell and inner plexiform layer, which is basically the neurons of the optic nerve. And if you have a sight difference in one of those layers of more than 6 or more than 4 micrometers, then you can say, okay, this is fulfilled. Again, as always in McDonald criteria, you have to rule out differential diagnosis. That is very important. There are different reasons why you can have asymmetric layers. But if you have done that and you see this asymmetry, you can see the optic nerve as fulfilled, and that gives you 1 of the 5.
Yep.
And then, of course, within the framework, that means that you have 1, 2, 3, or 4. If you have 4, you're finished. If you have 2 or 3, again, as we said before, and if you have 1, also you have different scenarios. And that is basically the main revolution, from my point of view at least, is that we have now the optic nerve in there, and we also get the OCT in there. Mm-hmm. And this also enabled us, if you have that, a diagnosis, to use it for different purposes as well. But I suppose we'll talk about that in a few minutes.
Go into that. I think one of the interesting things that you pointed out during that was talking about the different technologies and imaging technologies that can be used. I think that was a really important focus of this. We know that MS is a global disease. We know that geographically people have access to different technology. Imaging is going to be a big part of that. Can you touch just a little bit on that in terms of how these then are applicable to make it easy for people to use this, regardless of where they are in the world?
Yeah, that's for sure one of the reasons for discussion, and it's worth discussing that. Of course, we live in a world where resources are not distributed equally, and it will be available somewhere and it will not be available somewhere. The important point is that you don't need it for a diagnosis, so nobody is excluded from having a diagnosis just because this is not available. And in clinical practice, I think it will be not done in every patient. It will be done in those groups or in those patients where we are not sure about the diagnosis, like in a second opinion part of you. And that makes applicability already a little easier. Mm-hmm. There still will be parts of the world where this is a little harder. And it also will be upon us to create an environment where this information now is disseminated and where neuroradiologists and radiologists in the world are educated about why we need this susceptibility-weighted imaging. That's the important part. So not every MRI is made equal, and you need to do an additional sequence. It's not a complicated sequence, it's a common sequence, so that's a good place to start. But it's not incorporated in all the diagnostic MS protocols. It is in some, but in others not. And that will be the important part to, again, educate neuroradiologists why we need that and what the definition of it actually is, and then to put that into the clinical routine. That will take time, but that takes time all the time. Mm-hmm. I mean, we had the same with the McDonald 2017. This was considered also as something which will be very hard to implement because we basically changed the framework. And it's like that again. Yeah. That's the evolution of time. That's how life is. And it's upon us again to disseminate that. And that's basically what we are doing here.
Yeah, definitely. So moving beyond diagnosis, you said imaging has obviously always played a pretty critical role in terms of monitoring disease progression. But more and more we're trying to find advanced ways of doing that. And biomarkers is obviously a really hot topic at the moment in the field of MS research. We obviously have fluid biomarkers, which we'll leave to a separate discussion. But in terms of the imaging field, how are we using biomarkers in the imaging field to help monitor disease progression?
Yeah, then again, that's a discussion which we could have like for 3 days. So yes. for the interest of time and also for the interest of our listeners, we will keep to the biomarkers we talked about. There are a lot of different ones, and I hope nobody is disappointed that I didn't talk about his or her biomarkers, so we stick to the ones we just talked about. And then from the 3 we talked about, we have to take one out of the equation because the CVS, the central vein sign, is a very good diagnostic marker, but it's not a prognostic or monitoring marker. Mm-hmm. So there are very little studies finding any values in that. And when it does, it is mostly to distinguish whether a new lesion is actually MS specific or not. Within that context, you can use it. But that is also possible in other ways. So I'm going to refrain from talking about that now. But the other 2 may have a very big role, or a big-ish role at least. Again, starting with the MRI, with the PRLs, so we can very easily distinguish is a lesion iron rim or not. And of course, you use that for diagnosis, but you use MRI also for monitoring. So you do continuous MRI re-evaluations. And what you basically do in clinical routine is see, is there any new lesion? You count them. Sometimes you give also volumetric analysis where that is applicable. But you also can see whether this new lesion is iron rim lesion or not, or whether you have iron rim lesions in the beginning. Mm-hmm. And again, there is a difference between a prognostic and a predictive biomarker. So a prognostic biomarker is something which gives you information at time point 0 about the future, and a predictive biomarker is that again for treatment response or whether you monitor it over time. The PRL is for sure a prognostic biomarker. We know very well that patients who have PRL at the time of diagnosis or at the time of treatment start have a higher risk of disability progression in the future. So you can use that. If you have one or not, it's prognostic, and if you have 4 or more, then it's even a worse sign. That is pretty well established. And for that, you can use the same protocols and you get the same information basically very, not cheaply, but very easily if you have it. The same is basically true for the OCT. So now, depending on where you are and how established the method is, you will have that at diagnosis. And if you have that at diagnosis, it's not only good for telling you whether you had optic neuritis, to tell you whether the optic nerve was affected for diagnostic criteria, as we said, but also for prognosis. And again, we already talked about the layers, about the PRNFL and about the GCIPL. There are now well-established cutoffs also for prognosis. So for the PRNFL, it's about 88 micrometers. So less is always worse with this content. And the GCIPL, it's a little less clear whether it's 77 or 70, somewhere in between, but below 70 is certainly not good. There's maybe a gray area in between, and above 77, it's basically better. So if you are either both normal, and it's important to distinguish that that is not meant to be after optic neuritis. So you do not count eyes who had optic neuritis. Of course, they will be thinner, but others who didn't, you use that. If you never had optic neuritis, you use the average of both eyes. If you had optic neuritis, you use just the eye which did not have optic neuritis. You cannot use it if you had bilateral. But basically, at the time of diagnosis, that should not have happened if everything went as planned. And when you have that, so when you have thinner PRNFL or thinner GCIPL than these cutoffs, then again you get an independent additional prognostic information. So in addition to all of the others, to the clinical markers, to the routine imaging markers, you get an additional odds ratio of like 3 to 4 times. So people in this lower bracket, they definitely have a worse prognosis per se. It's not completely clear right now whether if you treat those more aggressively, whether that actually helps you out. But it's very much anticipated given what we know about other biomarkers. So that is the prognostic part. And then, of course, we have a predictive part. So you can, again, with a similar way of the MRI, you can do OCT time and time again. And there's basically 2 applications where it may be very useful. I say may because the study landscape is not that huge yet, but there are at least those there are show pretty much the same, which gives us a little more confidence. So when you had your basic OCT and when you suffer optic neuritis afterwards, so after diagnosis, and you do another OCT like 3 to 6 months after you suffered the optic neuritis, then you see how much retina was lost. And that may be very little, or it may be quite a lot. And very unsurprisingly, the more you lose, the worse it is. And meaning in 2 things. The more you lose, the less likely you are to recover from this optic neuritis, so to regain the vision you had before. But it's not only that, because that would be a little bit of a self-fulfilling prophecy. I mean, if you lost a lot, about 6 months, then surprise, you're also less likely to recover. But if you have another relapse after this optic neuritis, which hopefully never happens, but if it does, if you lose a lot at this optic neuritis, it also means that your likelihood of recovery about the later relapses is also lower. So for us, that means that if we see that, we're basically at a time where we do not tolerate disease activity at all. But if you choose whether this is your first treatment or if you're in between, whether this is this really highly active treatment or maybe not, that is a sign to go towards highly active treatment or highly effective treatment. That is one application. And the other one is if you do the MRI, the OCT as you do the MRI, so like every year or every 2 years under the same treatment, you can see thinning. And thinning over time is happening in all of us, or at least in all of us over 30. That is normal aging, but that is very little, and it's like 0.1 micron. Or 0.2 microns, depending on your speed of aging. But in people with MS, it's a lot faster and it's a lot stronger. So you have 1 to 2 microns per year. But that is very much dependent on your course. So if you have during that time EDSS progression or disability progression or even isolated cognitive progression, you have faster thinning and it's less if you're stable. And it's also, and that is the encouraging part, it's better or less atrophy over time if you're under highly effective treatment as opposed to the others. It is currently not entirely clear. We have a poster here on Friday, which I will not present here because it's not out there all the time, but which shows that this actually will add on to what we already do in monitoring. But honestly, that has yet to be determined whether it really gives us something independent. But at least it gives us a surrogate for a neuro-axonal damage over time, which we are currently a little lacking because the MRI atrophy is there, but it's technically very complicated. And the OCT is, in comparison, technically a lot easier. Yeah. So personally, and that is my personal view, we will come at a point where OCT will end up in monitoring, or at least in studies when we want to see how neuro-axonal damage behaves over 1 or 2 years.
Yep. It's really interesting. Shifting slightly in terms of treatment monitoring, but also really interested in terms of how that then fits in clinical trial design. What are sort of the imaging gold standards now that are being used in that? And also really interested in your perspective in terms of remyelination trials, because that's something completely different really from what we've done before, where we're really trying to find the best ways of measuring myelin repair.
Yeah, that's of course a very interesting field, and in all honesty, a field where we are badly lacking because not only have we trouble developing a drug, but we also have trouble finding the best combination of biomarkers to actually measure what we are really doing or what a certain drug would achieve. I mean, there is, I think from my point of view, again, a very good role model, and that is the optic nerve. So there is a study, or basically some studies, which have shown that a combination of OCT together with VEP in the context of acute optic neuritis is a very good combination to, on the one hand, give you myelin via the VEP or remyelination, and on the other hand, measuring neuro-axonal damage over time with the OCT. That has been tried in phenytoin with a little mixed result and not really leading to something which we really desire, but at least it was a proof of concept. And I'm pretty sure that if we end up with a drug which really gives us remyelination or actually prevents neuro-axonal damage over time, that is maybe the easiest model to use, at least in a phase 2 design. And basically then also for a phase 3 design. I mean, this has been tried before with, unfortunately, not a breakthrough success, but these are the markers, of course, together with some MRI sequence, which are a little more experimental or maybe a little far away from clinical practice. But in the case or in the context of studies, especially phase 2 studies like MTR, for example, is certainly something where in the combination, and also probably in combination with body fluid biomarkers, which are not our topic today, but we will need more than one, that's for sure. I mean, not to miss anything, and also to see whether this is actually giving us a consistent picture.
Yeah. I mean, it's a hugely interesting topic. There's so much we could talk about. It's a huge amount of information that you presented across the episode, so I really want to thank you for sharing your expertise with us today.
It was my biggest pleasure. Thank you.
Thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MS Translate. The ECTRIMS Podcast is produced and hosted in collaboration with 2 key partners: MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community, and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2025-26 ECTRIMS podcast series is supported by educational grants from Alexian AstraZeneca Rare Diseases, Bristol Myers Squibb, Novartis, Roche, Sanofi, and UCB. Educational grant providers have no input in the podcast content. Do subscribe to the ECTRIMS podcast on all your favourite podcast channels, including Apple and Spotify. Visit the ECTRIMS website, ectrims.eu, to learn more about this topic and more, and join the conversations on X, LinkedIn, Facebook, and YouTube.